Hello. Good morning, Dr. Sabhi.
Good morning, Mohammed.
Morning. Morning.
Okay.
Okay. Bismillah ar-Rahman ar-Rahim. Welcome everybody to Cardialex 2018. Our live transmission will start. I'd like to welcome Professor Dr. Antonio Colombo and thanks for his nice case yesterday. I present now the team in CAS Lab 1. We have Dr. Antoine Lefant, Dr. Ahmed Amrawi, Mona Hosni, the nurse, and Muhammad Kamal, the tech nurse. We have Dr. Ahmed Naguib, we have Ahmed Masoud and Ahmed Abdel Majid. We have in the outside also Ahmed Fahmi, Shahat and Sha'ban. Okay, in CAS Lab 2 we have Dr. Peter Kala, Dr. Sada'a, and as a manipulator will be May Abdel Menam. We have Ayman Hassan. We have also Amir Abdel Ati and Dr. Mustafa Ilwani, of course, Dr. Sada'a, and they will present to you the Dr. Mr. Ayman Hassan also. They will present two cases. I hope everything will be okay. I have no sound now. Dr. Sabhi, you are hearing him?
No sound.
Okay.
Can you hear the voice? No.
The voice?
No. Yes.
Okay,
Now we can hear you.
Okay. So I leave now. Dr. Amrawi will present the first case, and then Dr. Mustafa Alwani will present the second case. Go ahead.
Presentation. Good morning, Dr. Sabhi. Good morning, Professor Antonio Colombo. Welcome to ICC live transmission. Welcome to Alexandria. We have here a 59 years old gentleman. He is a hypertensive, ex-smoker, non-diabetic. He was presenting with chronic stable angina class 2 to 3 6 months ago, with no previous acute coronary syndromes. Next. His echocardiography is unremarkable, well-preserved ventricular functions, and he had a positive exercise stress test. This is a coronary angiography that was done. This is a coronary angiography that was done 6 months ago. It showed a tight lesion in the circumflex and a long calcific lesion in the LED, and the right coronary was PCI for the left circumflex was done using a DES 3.5 by 24 millimeter.
Well, next, Amraw. Well, next.
Next. Trial for dilating the LED failed after several balloon dilations due to the presence of tight calcification in the mid-segment. Next. And this was the final result 6 months ago. So we are facing a patient with failed PCI LED 6 months ago due to high calcium burden. His syntax score before the first procedure was 13, and the residual syntax score after performing the circumflex angioplasty is now 10. Next. And the Sentex 2 score showed a PCI 4-year mortality of about 4% and cabbage 4-year mortality of about 3%.
هتنقل لما تخلص برزنتيشن مصطفى علواني.
Calcific, yeah, calcific.
Yes.
Yes.
I think it was. Oh, Antonio. Yes. Sorry, Antonio. Go ahead, Antonio.
عايز تاول نشفة يا جماعة؟ نعم يا سيد. سقعان؟
Yes, I agree with Antonio that it was fair to start to dilate, and then since it was failed, at least this is a difference between a complication and a failure. And in fact, the patient was quite. The first question is, why did we wait 6 months to restart the LAD? And the answer may be that in fact he was partially improved by circumflex stenting in January. So now he is back to the previous clinical status. And we will show you, in fact, the angiogram, which is interesting, and also we perform an IVUS.
Yeah.
It's a little bit.
So can we run the angiogram first?
This is the angiogram for today. The circumflex stent is patent.
PT1, PT2, and to the LAD
To stabilize.
to stabilize.
However, now we have
See,
I had a total occlusion in the mid LAD.
الأولاني اللي معانا.
So in fact, we started with not a rotablator case, but a CTO case.
Yeah. Next.
So in fact, we used a PT,
PT2 moderate. Yeah, over a fine cross.
yes, and usually I like to go directly with the rotawire, but since it was an occluded, I didn't want to hurt it, and we considered it was faster and safer to go through a first wiring. And so we said that we are using a 7 French catheter, and now the discussion I had with my colleague is whether we should start with 1.25 or 1.5 burr, and I led the team, the discussion to start regarding the size of the burr. Do you hear something? I barely hear. A little more sound.
نطلب منهم يعلوا صوت. صوت.
Do you hear something?
Barely. No, very low.
No. No, I think the IVUS. Oh merde, encore Antoine, oui. I totally agree with Antonio. We could use 6 French, especially with the 1.5 bar. It works quite well. You can do the controls. In fact, we prefer to use IVUS than OCT because, in fact, you will see the IVUS is a wonderful image, and OCT with calcification doesn't bring anything else. And we had some doubt regarding the ostial LAD, and we wanted to have a clear idea on the left main trunk distal and the ostial LAD to be sure that there was not something wrong. And so, if you agree, we will show you the IVUS. Can we show the IVUS?
IVUS, please. We already did. We already did IVUS. Yeah. Okay. Right now.
This is. Yes. Can we run? Yes. IVUS. Okay.
Here is the IVUS.
Okay, the IVUS was starting when exactly at the point of the failed angioplasty at the bifurcation with the diagonal. And then we see that we have a quite large artery, and then there is stenosis with a plaque, which is the ostial lesion, and we measured the ostial lesion, and the measurements are very reassuring because we have between 2.8 and 3.3 millimeters, so there is no need to perform any stenting at this point, and so we will focus on the failed zone, which is more the middle LAD at the side in contact with the 2 diagonals, which are not very healthy, by the way. I think there was a debate. There was a debate between 1.25 and 1.5, and I was more. I considered that R9.5 was fine, but starting with this CTO and quite a small vessel, 1.25 would have not been a bad idea. At this point now, I think that we should start with the 1.5, having good measurements of the middle LAD, and also the evaluation of the ostial LAD was very interesting at this case. So we don't perform systematically IVUS before rotablator, to reply to your question. Yeah. We don't, but this case is complex. The spider view, yes, we will do it right now. Everything is live. Okay. No, we start with you. We waiting for you. Okay, so you go to the.
Would you like to go to the second room first, Dr. Sobhi, or to do the rotablation now? Okay. Okay, waiting for you.
Yep.
Hi, Dr. Sobhi. How are you? Hello, everybody. Everything is okay. We welcome you here in ITC CAS Lab 2. I have the honor to work with Professor Peter Kala. He's very well-known intervention cardiologist, and we are enlightened by his presence today. Also, we are glad that we... Dr. Sobhi. So now we are going to present our case. Dr. Alwani will present the case right now.
Good morning, Dr. Sobhi. Good morning, Chairman and distinguished audience. Our case today is a 52-year-old male patient. He's hypertensive and he's a current smoker. He presented on the 4th of March 2018 by non-ST segment elevation acute coronary syndrome. Thereafter, he complained of angina class 3. His lab test showed good renal functions. The echocardiography was done and showed preserved LV systolic function with hypokinesis of the epicoseptum and the epico-anterior wall. Okay. For risk evaluation, the patient's Euro score was 1.25%. His syntax score 2. His 4-year mortality for PCI was 2.8, and his mortality for cabbage was 2. Coronary angiography revealed long, tight, eccentric, approximate eccentric lesion in the LED, and proximal total and the proximal total occlusion of the ramus intermedius receiving collaterals from the left anterior descending artery. And here we can next. And in this view we can see the stump of the ramus intermedius. Okay, next. And here in this view we can appreciate the eccentric lesion in the proximal to mid LED in this tortuous vessel. Next. Here the right coronary artery, it's a dominant artery with a tight proximal lesion followed by an ectatic segment and then an intermediate lesion. Next. Okay, next. And this is our case today, Dr. Sada.
So, Dr. Sobhi, so did you see the case? هم سامعيننا هم هناك. So, yes, we have a very critical proximal LED with ectatic segment, ulcerated plaque. We have a very big ramus intermedius with CTO bifurcation, and then we have the right coronary artery with 2 consecutive lesions over a long ectatic segment. So what would you recommend? As you can see here, the syntax score 2 is even equal between PCI and cabbage. So we prefer to do PCI for such young patient. So we want to know your opinion about the case. طيب مصطفى ايه اللي على الكاس لاب التاني؟ بس ثواني بس لما نسمع الديسيجن نعرف رايهم ايه. Okay, so Dr. Sobhi, so for sake of time, we have to move because we have lost 30 minutes from the live right now. So now you are facing a multi-vessel disease, and as we can hear from you, somebody are, I think, favor to start with this LAD first, and other people are favoring do BCI for the RCA first. So I will let Dr. Peter show you what we did.
Okay, so we decided to start with the right that is really huge and dominant, but I agree that probably the culprit 3 months ago was the LAD, maybe also the Ramos. It's difficult to define. So we decided to start with the right because it's a very dominant artery, and after fixing the right, it would be much easier to be focused on the left system. The proximal part, the proximal lesion is definitely highly significant. What we discussed was the mid part of RCA and the role of fractional flow reserve measurement, but after that we decided not to measure after fixing the proximal lesion and to fix both lesions at the same time. So we can show you the final result after stenting. It was pre-dilatation and stenting. So we used 402 science experienced stents, and the whole stented segment is more than 60 millimeters in length. And after that, it was post-dilated with non-compliant balloon 4.5. So we will show you the final result after fixing the proximal and mid part of RCA. And after fixing this, so we are quite safe to approach the left coronary system.
Next. Next.
At the same time, we thought about the ramus, if it is the culprit, if it might be the culprit lesion, but it's not soft plaque, it's quite hard plaque itself, and so we are dealing with the CTO of ramus and, of course, ulcerated lesion of the proximal LAD. And you can see now some aneurysm in the proximal part of RCA that was visible from the beginning, but it's impossible to dilate the stent into the aneurysm, short aneurysm. So we are very happy with this result from the right. And now we are approaching the left coronary system. Yeah, I agree with you. Maybe, yeah.
So we took a 4.0 Zynes, two stents, the 23 down there and 28 up there, and we took a 4.5 Trek balloon. We took it up to 28 atmosphere. So I think the stent, it goes up to 4.6, 4.6.5, and I think we did an IVUS for such a patient, and we have some aneurysmal dilatation around the stent. We did what's called stent acquisition, and with the stent acquisition, can you see down there the stent acquisition? So it's clear that it seems all the stented segment is well opposed except a very focal aneurysmal dilatation, and I think nobody will do something for this small aneurysm. And now we are going to move to the LAD and the ramus. If you can see, we put a guide 7 French, XB 3.5. Okay, next, Ayman. And then we put a wire, next please. We have here, as you can appreciate here, we have a very small stump down to the LAD, between the LAD and the LCX. And next. Next. And here you can see a very huge, next, ramus intermedius comes from the retrograde collaterals from distal LAD. Next. So we put a PT2 light support wire in the LAD to secure it. Then we are going to hit this proximal plaque from the ramus, and I think it will be a very difficult job because the wire usually prolapse between the LAD and the LCX. So if you want to move to the other cast lab to see what's happening with Dr. Lafont and the rotablator, while we are going to try to hit this proximal plaque, and we'll get back to you again after 10 to 15 minutes. It's okay.
Hello again, Dr. Sobhi. No, we are ready. We are ready now for the late ablation to do it live with you. Okay, let's start to do the ablation. Camera down, camera down. Yeah. Here.
So you see the burr which is coming to the aorta. We are almost there. And then in order to help a little, I will use the yes. Stop. Okay. Okay, now we turn the tips and tricks in order. Yes. Okay, Antonio Colombo. J'ai toujours pas compris qui est-ce qui.
We can start to open now. Would you like to nitro and the lock and the brick.
Yes.
Brick.
It is 1.5.
That's okay.
In fact, we chose 1.5 because we consider that the size allows, and also if we get any problems with the 1.25, we will regret not to have used the 1.5, which is a minimal size that we want to use now. Can I have some flush? Can you yes, pulse. So we just injected nitro because I think it is absolutely mandatory. I moved the burr. So we are close to the, and now I switch from the slow speed, which allows me to go to the target, to the high speed. And we are going very slowly as okay, no, don't. Okay, and then we could do an angio now. Are you ready for angio?
Yeah.
How is the pressure? Pressure is low. Can we feel the patient?
Fluids.
Okay,
Fluid.
okay. So now we have to go further.
Further, yeah.
I think the burr is not going far enough. Can you increase the speed?
Increase the speed.
Increase the
Increase
speed, please. The speed is not far enough. Pressure. Yes.
Quiz?
I need to be around 200,000 because
It's trapped inside.
I don't want to be trapped.
Yeah. It's out.
Okay. Angio.
Angio.
I think we made some progress.
Yes.
One of our issues is the two branches which are really sick. Okay, the pressure is quite fine. We still have some branches, and we even have a better flow in the septal branch. And now we have to, I think there is a distal lesion, which is quite tough. But I have also a good sign, which is the increase of the size of the distal LAD, which is now much better than before. So I think it's important also to leave some time not to. Okay, we start again. Angio.
Angio.
Okay, we have to go to. I think it is.
Post.
Okay, Antonio, I think we have finished. I think. Okay. Very good. Now we could put a stent, I think, inside. Do you want to put IVUS?
Yeah. For life purposes.
Huh?
For life purposes. For life to
Yes.
future purposes.
To make
For a
it.
discussion.
Okay. I go down with Mohamed and Antonio. I am going out because I think it is enough. So I'll put a rota glide to get out. Be careful with the wire, please. Wonderful. Tap, 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 tap. Okay, be careful with the wire. Be careful because no, don't. Push the wire, please. I don't want to lose my wire. Push the wire. No. Stop.
Stop.
Push the wire. Push the wire. Okay, we lost it, but I don't know what you did, but it was not. Okay. I have no more wire. Give me the other.
We will move to the other cath lab and rewire and go to them again.
Give me another wire.
Yeah,
Yes.
yeah. Dr. Sobhi, we will move to cath lab 2 to see the progress there. Yeah, okay.
Now we first do an angio. We first do an angio, please. Are you ready? Yes.
So,
I don't know what happened with the wire.
I don't know.
Dr. Sobhi, can you see us? Okay, so now we are in the last few minutes we put a PT2 wire in the LAD, as you can see here. Then we took a pilot 50 first, trying to hit the proximal plaque of this bramus intermedius, but unfortunately the wire usually prolapse into LAD or LCX. Then we upgraded to pilot 200 and the same problem happened. Then we took a fine cross microcatheter to put it over the proximal stump. Then we changed it to Gaia second. So now Dr. Peter trying to hit the proximal plaque with Gaia second, but the same problem here. Trying to hit this plaque, usually the wire prolapse either in the LAD or the LCX. So did you suggest any solution in such situation?
Now we have Gaia second and fine cross. Okay. Yeah. Can we show the angio?
Can you see the angio of the LA left system? I think this ramus is a CTO. It's a chronic total occlusion with a long-standing duration.
And the next.
لا يا أيمن اللي قبلها اللي
Ah,
قبلها.
okay.
أيوة.
That was good. It was
Yes.
good.
Yeah,
The last one
أيوة.
was good.
This one is okay.
Uh-huh. The problem is that the stump is very, very short, and so we don't have good support. But we will try, and so if not successful, of
We'll
course,
stand the LED.
so we will stand. Yeah. Yes, exactly, because in such. Yeah. So I am. Yeah. Yeah, so I have the same opinion, because from FAME 3 trial we have several patients, and it's possible to left alone such CTO. It's and it's we will fix the LED. So I think that we will continue with maybe three more
Yes,
minutes.
give him 5 minutes.
And
Trial.
if not, so we will fix the LED and leave alone the Ramos. And I'm sure that the patient will do very, very well.
Yes. So any other opinion from the floor?
Live? Can we go live? Is it
Live, yes, yes. Ayman,
It's not live.
screen Ayman.
This is live. Yeah. Maybe we can prepare 2.5 for the pre-realization of LED.
Yes. حضرتك بالونه 2 ونص
Original one.
Yes. Actually,
Yeah, the roadmap is perfect here. Yeah, I like it as well. Yes.
So you stop.
Yes.
And I will raise something here. If we succeeded, if you succeeded to open this ramus, we are planning from the start to put a V stenting, one in the ramus and one in the LED. But after, I think we are trying since 20 minutes to hit this plaque, and we are taking by the advice of Dr. Colombo. And after the last publication from Park about CTO, you can leave it for medical treatment. With residual syntax score, I think it will be less than 8. So we'll tackle this big LED right now.
Yes, yes, exactly. This will be the strategy, and I'm not sure really that after fixing the dominant right and LED, there will be some residual significant ischemia. So maybe some, but I'm not so sure, because the collaterals are quite good, and they will be even better after fixing the LED. So I'm sure that it should be okay.
Can you see the coronary dynamics here? We can adjust the balloon in the lesion without injecting more contrast, as you can see here.
Now we are okay, we are fine.
We'll take it now, 2.5 by 15, to predilate and prepare the lesion.
So we use the same balloon like for the right. And with this 2.5, of course, there is no geographical miss that we would like to avoid. It's very small.
يلا صورة.
Can we inflate?
It's okay.
Yeah, predilate, dilate. But the road mapping is perfect. The road map is really great. So now we are ready for stenting, and the size now again it's a matter of discussion about the role of imaging, because not in all labs we have the imaging like OCT or IVUS.
هات كرينيال يا أيمن 30. Yes.
Yes.
And we'll see you the result. Okay.
Yeah, the very early, yes. Yes.
صورة بسرعة. صورة بسرعة.
Okay. So in fact, we show you. Can we show you the angio before? Yeah. So in fact, as you heard, we lost the wire simply because the wire was locked inside the rotablator system. So there was no way. I don't know why, but it was locked. But we just exchanged wires, and then we performed the angio. And this is the last angio without any wire. And you can see that there is a clear improvement of the septal branches. But on the left, the second diagonal, I think, is about to disappear. This diagonal is less than 1 millimeter. If we can avoid to lose it, we will do our best. But there is no way to protect it when we will stent. So what we did is we just perform an IVUS to check the size of the. And the question is, what size of stent would you use on the rotablated LAD? Or even would you use either DCB or a stent?
Oh, stent.
Or would you leave it like it? No, 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 we don't, because since I think we broke the plaque, and we want to try to spare the second diagonal, and the least the maneuver, the better chance to have it surviving. So you can see the IVUS on the top, and in fact the size is 2.5 at the minimal. The question is whether we should balloon it or not. So what does the panel say regarding the ballooning? Would you do direct stenting, or would you do no balloon? Zero balloon. And what about the second diagonal? No, I mean, I ask the panel what should be done, because it's a very long lesion. It's a small diameter, and we know that yes, but we know that we won't stent it. We won't stent this diagonal. When we lose it, we can still balloon it, but no. Okay.
او 12 او 16.
Now what we
اوكي يلا.
what? Okay. Okay, let's predilate.
2.520
2.5.
Yes.
by
Yep.
20.
By 25. Why
20?
20? It's a long lesion.
So as you can see here, before Ayman, قبلها. We took here a Zines by 3.5 by 23. Actually, we don't have 4. Then we took it up to 18 atmosphere. Next. Stent boost. And this is with a stand boost. It's very well deployed. Then we will take 4 wire, please. Live Ayman. Yes.
It's diagonal. I will leave it here.
Test. It's okay. Have some resistance. It's okay. It's okay.
Yes.
Stand boost.
So we are ready for post dilatation with NSC balloon
Stand
for
boost.
all.
Stand boost.
And again, maybe the imaging here. Okay, now we are perfectly.
Okay.
Okay, very good position. Because the balloon is well, maybe we will go 1 millimeter behind.
Proximal.
Is P2
Proximal.
okay.
Stent acquisition.
It's a NC balloon 40.
Stent acquisition أيمن. Stent acquisition أيمن. acquisition بصبغة. وقف النفس يا سعيد. هات بقى 60-20. We can take some nitro because of the some spasm distal. You can see here. وش يا ايمن. وش. اوكي. هناخد بس ثانيه نريح الميوكارديا. يلا صوره. وقف النفس يا سعيد. It's okay lateral من فضلك. Without wire please can you take the wire out.
I removed a little bit.
There's some
This should be
distal,
okay.
yes.
Now it should be okay because it's angulated.
Yes.
Angulated.
انزل بقى ترافلنج يا ايمن بقى. ترافلنج يا ايمن. داون يا ايمن. بس يلا صوره.
Yes, test. Yes.
Go down.
Go down يا ايمن. Go down يا ايمن.
Then we bring
okay.
a stent.
Yes.
Yes.
Yeah, we can hear you.
So can you see the final result of this LAD, Dr.
We
Sofi?
pre-dilated the artery with 2.5 20 non-compliant balloon, and now we are about to stent it with 2.5 38.
It's a very big collateralized from this distance.
Premier.
Yes, of course, it's very well
So I think
collateralized.
that now the collaterals are much better.
Yes.
So I think that
Yes.
there will be
Yes.
no
Yes.
no
Yes.
ischemia.
Yes.
So that was the
اخر
point.
صوره بقى كرينيا لايمن وخلاص. لو بص لو
Not yet, because
Not yet.
we are.
Yes, Dr. Amr, I can hear you. Yes, I can hear you, Dr. Amr. Yeah.
It is not. We are about to put the stent.
After the pre-dilatation.
نفس جامد وخليه بقى.
شغل آخر صورة. آخر صورة. Yeah.
And by the way, we broke the balloon.
الحمد لله بالسلامه يا سيد. نفس عادي. الحمد لله بسلامه. زي الفل يا جميل. Thank you.
Yeah, it was very nice.
So is everybody happy with this final result of LAD?
Thank you so much.
We are about. You see the stent. Okay, test.
You're welcome.
Welcome.
Thank you.
Test. Okay. You
Thanks
can
to the
see
team.
we are
Thank you.
putting the
Thanks so
stent
much.
right now. Okay. Go.
Now.
Test, please.
Test.
Test. Okay. Just a little. Okay.